if you're going to make this commitment to having higher testosterone levels, it's also very important that because you've got this Achilles, that you're really supporting your body with the proper diet, the proper nutrition, the proper lifestyle factors, because otherwise you could be putting a bit more of that stress on the heart, which is why it's so important.
Why using TRT would increase your risk of, heart disease, and maybe perhaps segue into what are the other potential negative side effects of using TRT? Because, I'm sort of, we hear a lot about all the positive benefits of TRT, but I'm also, more concerned, what are the negatives that come with it? So cardiovascular, obviously one end, but what are the other concerns, we should be thinking about?
That ties into a lot of what I was about to say, but I'll let that question get answered by the experts, because I would say that that's not true, but that's not my definitive call to make. But just jumping on this as a case study, the lens that I would be looking through something like this at is saying, your heart would be your Achilles heel if you're in this kind of situation. And I think what's important is, looking at testosterone replacement therapy as a way to give you the quality of life back, give you the performance back, the well-being back, but also recognizing that if you are going to do that, it's kind of like you're upgrading your engine in your car. So you need to be working on upgrading all the other parts around the car and making sure you're a good driver, because if you're going to make this commitment to having higher testosterone levels, it's also very important that because you've got this Achilles, that you're really supporting your body with the proper diet, the proper nutrition, the proper lifestyle factors, because otherwise you could be putting a bit more of that stress on the heart, which is why it's so important. And Dr. O'Connor had a great term. I think you said like health in reserve for younger men. I think that's a great term. I hadn't heard that term before. And this is something where we're looking at going, okay, this is kind of the opposite of that. We don't have that health in reserve. So that makes it very important. And, Luke talks a lot about the importance of things like cardiovascular training, making sure that, your body is fit and healthy. And I think that would be a really important lens to look at and go, okay, if I am going to go down this hormone replacement therapy path, I need to look at it holistically in terms of being like, what's going to give me the ability to tolerate and thrive with these optimal androgen levels? And this topic that we spoke about before on the panel this morning, which is how can I meet the treatment halfway in terms of putting in the testosterone as the foundation, but then using that to, I guess, supercharge or further augment the diet lifestyle practices that would come in place with living a heart healthy lifestyle.
So from my experience, what ends up happening is guy doesn't feel good, guy goes to a TRT clinic or goes to the doctor, guy gets on TRT, but doesn't address why his testosterone was low in the first place. So they could have metabolic syndrome, they could have cardiovascular issues, they could have a plethora of things, but they think taking testosterone, that's what's going to fix them. So the same thing as if you have high blood pressure, they give you a couple of pills and doctor said you're going to be sweet, but you don't do anything to offset why you needed the medication because your blood pressure was really high. So they end up getting on T thinking that's going to be the thing that's going to save them. They ignore all the things that they actually need to do with testosterone as being the, adjunctive therapy. And then they end up getting a heart attack or a stroke because they didn't deal with the shit that made their testosterone low in the first place, right? So like a lot of this stuff is helpful, right? If you look at things like blood pressure medication for me, unless you have a genetic reason and you just can't get it down, it should be a Band-Aid until you get your shit together, all right? But that's what people don't want to do. Give me a magic pill, potion, give me an elixir that's going to fix all my problems so I don't actually have to address the real issue and actually do something like, exercise and watch what I eat and eat better quality foods.
So that's a great question, because what you said is that testosterone may have a lot of benefits, may be good for a lot of things, but we all know it's bad for the heart. And that is something that I think comes from sourced in part from FDA. In 2019, FDA put a black box warning on testosterone and said it's linked to causing strokes and heart attacks. And so the mainstream media has gone with that narrative. That's really what you read. Lawyers, not me, but the bad guys, the lawyers we don't like, immediately seized upon that and filed class action litigation, which was consolidated in a court in Chicago. It's still going on. They sued the makers of all of the gel type products, saying two theories of liability on the part of the testosterone manufacturers. One, that they didn't disclose these cardiac risks. That, yeah, testosterone is bad for your heart, and you didn't tell the patients, and the patients suffered consequences as a result of that. And secondly, their claim was some of you, how many remember the commercials, "Is it low T?" that was on television? Okay. So there were commercials that were putting that out there, and the claim was there is no such that's not a disease. Low testosterone may be linked to diseases, but it's not a disease in and of itself. And so those were the theories of liability. I'm not a doctor. I've never played one on TV either. But so I'll leave it to these doctors to say, but I've actually looked, as I'm sure Luke has, at the literature and the studies upon which FDA based that conclusion. I'm just a lowly lawyer, but I was far, 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 far from convinced that that was a valid basis or that that black box warning belonged on there. But I'll open it up to the doctors to share their thoughts on that.
So the new data say that testosterone is beneficial for the heart for two reasons. Mainly, it improves the nitric oxide, which is a vasodilator to the coronaries, so more oxygen can be supplied to the myocardium. And then it can reverse metabolic syndrome by burning the visceral fat and improving the lipids. Now, I believe the only concern of the medical society, the stubborn, skepticistic, is what Michael discussed in first place, the erythrocytosis. So testosterone and androgens treat anemia and fatigue by kicking EPO. Now, some people are more prone to this, but this is classic. Actually, is the most standard side effect to some people, the elevation of the hematocrit. And this actually could be linked to a higher viscosity. And this higher viscosity, along with other factors, could be linked also with stroke, okay, and heart attacks. So, but even this can be managed. And actually, I know people that use tons of steroids and do not elevate their hematocrit. It's something genetic. It's also has to do with smoking, with sleep apnea, with living in high altitude. But secondary erythrocytosis, that means elevation of the hematocrit and hemoglobin as a result of the external stimuli, which is either smoking, either high altitude and hypoxia, either testosterone, something that is not linked with primary erythrocytosis, such as polycythemia vera. That meaning, in first place, a genetic mutation that elevates the hemoglobin and the platelets, and then you have higher tendency of clotting. So how many people who live in Colorado or in Mexico have to be phlebotomized, and how many of them die out of a stroke? The same happens with testosterone. So is it actually as crucial as living in a high altitude? But I believe this is the main concern. They see a hemoglobin over 18 and they panic. And they say go for a phlebotomy or a blood donation. If hemoglobin is below 18, they take an aspirin, for instance, hydrate a lot, so manage this high viscosity. But I think this is the only concern that the medical community is aware of. And actually, this is to the old data. And the new data says that testosterone is beneficial for the heart, and even this can be managed.
Well, that's a good segue into the next topic that came from our poll. What are the effects of hematocrit, hemoglobin, red blood cell count on the heart, and how much of it is due to testosterone replacement? I think we all know how much is the hematocrit, the hemoglobin issue. Obviously, maybe dose makes a difference on testosterone. Some of this, the guidelines in Europe and the UK talk about if your hematocrit gets up to 54%, then you may want to look at stopping therapy, trying therapeutic phlebotomy. I think one of the guidelines even talks about a baby aspirin as part of the treatment modality. But there are different guidelines in other locations. But just changing your dose, being aware of it. Let's talk about what that would require before we get into the actual dose discussion.
I want to go back to the cardiac stuff. This is kind of my day job. Back in the day, there were two studies, a JAMA study, right, 2013, I believe, that showed that it was a VA study, actually, that was met in the Veterans Administration hospital system. They looked at the data and they saw some scary, it was meta-analysis retrospective, okay, so it's not the best data. But the data showed that it looked like within a period of about 6 months to a year or so, the men that started on testosterone had a significant increase in outcome of stroke, significant heart disease, and death. And that's it. And then there was another study after that that was done, I believe, in a cancer journal, and they extracted secondary information out of that, and they concluded again that there was subsequent potential risk for coronary artery disease. Okay, and therefore, the federal government, I watched this very closely because I was directly involved with taking new patients and steroid users and middle-aged men and diagnosing hypogonadism myself in the state of Connecticut at that time. So, looking at the data, so that subsequently the government had ad hoc, a lot of meetings on this, the FDA, and I think they were trying to do the best job they could back then. And they did put that risk. They put a black box warning, the FDA, on all testosterone products, saying it can cause heart attack, stroke, and death. Okay, now here we are today. Subsequent to that time, some of my colleagues at Harvard and Cleveland Clinic, Dr. Steve Nissen, who's a colleague of mine, is probably the #1 cardiologist in the world, Steve Nissen, has broken down the data. This is over years. This is how medicine works in legal. They look back and they decided that the studies were fraught with all sorts of statistical error, but they already put the FDA warning on. They've already scared doctors. So I could tell you now, here we are today. Have you heard of the Travers trial? You guys know the Travers trial. So the Travers trial just came out. We never had a randomized, double-blinded, placebo-controlled, forward-moving trial looking at the safety of testosterone on cardiovascular health until now. So it's recently been concluded in the last year or so. It was run by the guys at Harvard and the guys at Cleveland Clinic. Steve Nissen is, I believe, the chief on this. So here's what they found. Men that are high risk for heart disease, they enrolled men into this trial that have heart disease and were at high risk for heart disease. They didn't enroll regular guys like you without heart disease. And they didn't look at CT angiography and calcium scores to see if you actually have heart disease. They took men that have they have heart disease. And then they enrolled men, that's stents and bypass. And, this gentleman here would have been a candidate for that, okay? Stents, bypass surgery, stents, acute coronary syndrome, and they enrolled them. They also enrolled other men that had significant risk factors for heart disease, diabetes, significant hypertension, hypercholesterolemia, maybe family history, maybe they're smoking, okay? So, but they're not regular guys who are just otherwise pretty healthy, okay? And they had hypogonadism. They all had hypogonadism, low T. They randomized it, right? Double-blinded it, and they gave the one group testosterone gel. I'm sure this company is very happy about this, right? And they gave the gel to one group, and the other group they gave just a sham, just a gel that doesn't have any active testosterone. After the study was concluded, and the study was done very, very well, no increased outcome in heart disease for the men that are on testosterone. So there you go. There's the good news. Now, I could tell you this. I'll close on this one. Unfortunately, and I'm asking Dr. Nissen if they're going to discuss this, all the patients that were enrolled in the Travers trial had heart disease or they're high risk for heart disease. They're on cardioprotective medicine. So if you go on testosterone and you're not identified, your A1C, your blood pressure, your cholesterol, your family history, if you don't identify your cardiac classic Framingham risks and work on those with or without medicines, you're not in that study. So I'm very confused and very frustrated and very angry that they're not telling people. This is all over the news, but you haven't seen this Travers trial? It's all over CNN. It's all over. Testosterone's safe. So you see the pendulum's going back over. Right, Rick? Right? But you have to understand the devil's in the details. It's a randomized placebo control. It's not retrospective. Those were not well done studies. So those were really errors they made. Now, is it safe for the heart and all this stuff? That's not going to be, we don't know. And if you're talking in vitro and in vivo, this is all the animal stuff. You take testosterone. If you take it, you need it. You take the lowest dose you can and manage your ABCDs. A1C, blood pressure, cholesterol, and be aggressive. Like this doctor over here says, be very aggressive so you can enjoy. I take testosterone, even steroids sometimes, but my ABCDs are that of a 12-year-old's. But I'm on very complex medications. I'm on metformin, 2 blood pressure medicines, right? I drink every night and I like to eat food, but I'm just trying to be a real person. But I like testosterone and steroids because I like to still bench press a lot of weight. And I'm almost 60. So, and I cleared plaque out of my artery with my medical regimen. See, I like traditional doctors. I like cardiology doctors. And I thought, what can I just take their medicines and repurpose them to protect people that before you have a heart attack? So that's why, in my opinion, when I manage my patients, I hammer on A, B, and C, and D is the deposition disease. That's the androgen-induced erythrocytosis that Dr. T is talking about, and this is multifactorial. And there's no direct data that's going to implicate any one of these really directly on a risk factor basis, on a sole basis, leading to outcomes in heart disease. But if you have hypertension, that increases heart disease. You take too much testosterone, you're hypertensive. Isn't that going to lead to heart disease? If it takes your HDL to the ground and your LDL up, which it may, depending on who you are, of course, your diets and all, it's going to, so if you take testosterone, you could have a heart attack. You could have a heart attack anyway. So, but if testosterone causes hypertension, because it can, right? Testosterone can cause hypertension, especially if you're taking too much. And it's not just blocking the estrogen. So do you understand? Okay, so the Travers trial shows currently, if I had 2 minutes to talk, testosterone's safe for the heart now. Is it really safe for the heart? You could have a heart attack anyway. So testosterone can just exacerbate some of those things. I mean, none of these doctors are going to disagree. You're not, right? You guys are going to disagree with that? No one's going to disagree. So I want people to be more aggressive with your cardiac risk factors.
I want to make a comment because I think George was talking about this. That some of the recent data shows that the secondary erythrocytosis that is induced by like living at high altitude. I live at a very high altitude. I see ultra endurance athletes who are running at 10,000 feet. They have hemoglobins and hematocrits that are higher than anybody who's now being told off to go donate blood. We don't tell them to go donate blood. We have athletes who come to train in Colorado so they can increase their hemoglobin hematocrits. They can increase their EPO. Secondary erythrocytosis likely, and we don't know this for sure, but does not have the same consequences as primary, which is a disease state that's creating, like polycythemia vera, which is creating a high hemoglobin hematocrit. And there's a lot of data supporting that we shouldn't be so overly concerned. Obviously, if it gets way out of hand, I'll have people go donate blood. But in general, we're probably gotten a little bit overly, and I think that's the point you were trying to make, George, is that this secondary issue is a little bit different than a primary erythrocytosis, which is a disease state. It's not the same.
Yeah, I just echo that. I think what's happened is through the years, it's been the terms have been commingled. Polycythemia vera is a primary, is almost like an autoimmune condition. It's a qualitative defect in the platelets and the blood cell lineage where all the blood cell lines get affected. So through the years, everybody's thinking kind of like estradiol and estrogen. It's not really the same thing, but it's been commingled. So when you talk to a hematologist or your family doc, oh, you got polycythemia vera. Well, no, testosterone causes an erythrocytosis. It can, not always. If it's managed properly, it may be just fine. But all the other blood counts are normal, just the red blood cell counts because of its action in the bone marrow. So those terms have been kind of commingled. And so you talk to hemologists, say, oh, well, you could get thick blood. You could get a clot. Well, could just means it hasn't. There's no study. There's never been shown. But it could, but it hasn't. So you can go back and forth and play these games, but it's true. It's kind of like with clots. Like there's never been a study showing that. So, erythrocytosis is very different from polycythemia vera. These two doctors said, the secondary kind from altitude, from testosterone, totally fine. People, and I agree that we're seeing more and more studies now. I just read multiple just recently showing how overzealous, blood donation, all these things can actually cause a rebound effect. You can actually cause clots. You can cause some endothelial dysfunction. You can cause anemias and all these other things. So there's really no reason to do that. Again, smokers, Sherpas, people living in Colorado, they don't donate blood, right? And they're just fine. So, yes, if you're doing 1,000 milligrams of testosterone, your blood count's going to be ridiculously high, but that's a whole different story, right? So what we're talking about here is therapeutic uses of testosterone. You're going to get an erythrocytosis, which is normal, and there's no reason to do anything with that, as long as the other counts are fine. Now, if they have an abnormality in their platelets or something else, yes, that's a completely different story.
All right, guys, this is my day job. So A, B, C, D, right? A1C, blood pressure, cholesterol. D stands for deposition disease. And as these doctors talked about, here's what's going on. It's called androgen-induced erythrocytosis. It's differentiated from polycythemia vera, which is really a pre-malignant condition, and it's a very complex condition. It's genetic, and it's very rare. But when hematology and internal medicine doctor is going to get a patient with this, they're going to start checking for JAK2. They're going to start checking for this to make sure, because that's what they do. Here's how I see it, and here's how, because I've done research with this with hematology doctors on this. So it's a multifactorial situation. Okay. When you take testosterone injections more than anything, you're going to see a very powerful potential stimulation of the red blood cell line. Again, androgen-induced erythrocytosis. Here's where the danger is. If you're just looking at the hemoglobin and hematocrit, and you're not looking at the ferritin and the iron studies, you're going to be in trouble. Because if you have, say you're a man that you're from a Caucasian Northern European man versus a man who's African American or a Mediterranean man that has maybe some thalassemia. Okay, this is all how the stuff works. You have genes that are underlying. And if you take testosterone and you have hereditary hemochromatosis, because I have these guys, I have them, it's gonna exacerbate the uptake of the iron, not just to mention the erythrocytosis itself. And if you're not looking at the iron studies and the ferritin, you can die. You're gonna die because you're looking at iron overload, which is that's hereditary hemochromatosis. And if you have that gene, 10% of Northern European men have the gene. And when you take antigens, it's very complex. Now, other things and I look at the upper limit normal of hemoglobin hematocrit is 18 and 54. That's it. It's not 17. Your doctor is going to say 16. It's wrong. They're wrong. A lot of anti-aging places and a lot of guys get the information on the internet. They're self-lobotomizing. They want their hemoglobin to be 15 or 16. Now, when you do that and then you look at your iron levels, you're going to be depleted massively. You're going to be completely iron deficient. So these are the things that I picked up over the last 20 years. And I work with hematology doctors, real academic hematology doc. And they told me years ago, they were like, it's interesting. We're looking at this where it's antigen-induced erythrocytosis, but we're looking at it as if it's a primary polycythemia when it's not. And we don't know the data. Like, I could tell you that I don't like patients to live at 18 or over 18 very much, or 54, but you can, but you have to balance it. You have to look at the iron study. This is what you're going to have to do yourself. Look at the iron studies and the ferritin and see where that is. And you don't want to you just can't phlebotomize because it does make it worse. But if you have obstructive sleep apnea, if you're if you're up in a mountain, and I've had guys that have sleep apnea, live in Colorado, have some of the genes for hereditary hemochromatosis, and they smoke. Imagine that. I have to phlebotomize them. So I phlebotomize guys all the time. But I don't like them to live much over 18, right? Do you guys agree? You're going to let a patient sit at 19? Right. I don't feel so. And I refer a lot of patients to other doctors that are hematologists that I trust in America. So, but my cutoff is, but I don't phlebotomize 17-1. A lot of the anti-aging doctors you're going to go to, they're going to just phlebotomize 17. First of all, some of the clinics just mandate that everyone phlebotomizes. That's completely wrong. I have guys, when you look at these young guys out here that are on a gram, it's actually not necessarily a dose-dependent phenomenon. You don't see it. It's multifactorial. Because I have guys that are young that are on a gram or two of steroids, and their red blood cells are, wow, because they have thalassemic protection. Again, it's very complicated, but it's very cool. But you got to look at it. And so again, and if you have, I take care of a lot of law enforcement and military men in this country, even abroad. And these guys go in and out of planes, so they're in and out of planes that are not pressurized. So they've had DVTs. So a guy has a DVT, that's a venous thromboembolism, right, which is a clot in the lower leg that called pulmonary embolism. It's not on the arterial side. That's a heart attack. It's complicated, but it's kind of hypercoagulable. It's kind of all the same thing. That's the aspirin and all this stuff. But if you have a genes for that, like factor V, von Linden, right, and then you're having DVT, you can't let that patient have a hemoglobin of anything much more than 17 to, see, I have different ranges and I have to work with other, but when you send the patient to another doctor, they just say, stop testosterone. And they told me years ago, they were like, it's interesting. We're looking at this where it's antigen-induced erythrocytosis, but we're looking at it as if it's a primary polycythemia when it's not. And we don't know the data. Like, I could tell you that I don't like patients to live at 18 or over 18 very much, or 54, but you can, but you have to balance it. You have to look at the iron study. This is what you're going to have to do yourself. Look at the iron studies and the ferritin and see where that is. And you don't want to you just can't phlebotomize because it does make it worse. But if you have obstructive sleep apnea, if you're if you're up in a mountain, and I've had guys that have sleep apnea, live in Colorado, have some of the genes for hereditary hemochromatosis, and they smoke. Imagine that. I have to phlebotomize them. So I phlebotomize guys all the time. But I don't like them to live much over 18, right? Do you guys agree? You're going to let a patient sit at 19? Right. I don't feel so, and I refer a lot of patients to other doctors that are hematologists that I trust in America. So, but my cutoff is, but I don't phlebotomize 17-1. A lot of the anti-aging doctors you're going to go to, they're going to just phlebotomize 17. First of all, some of the clinics just mandate that everyone phlebotomizes. That's completely wrong. These are complete. I have guys. When you look at these young guys out here that are on a gram, it's actually not necessarily a dose-dependent phenomenon. You don't see it. It's multifactorial. Because I have guys that are young that are on a gram or two of steroids, and their red blood cells are wow, because they have thalassemic protection. Again, it's very complicated, but it's very cool. But you got to look at it. And so again, and if you have, I take care of a lot of law enforcement and military men in this country, even abroad. And these guys go in and out of planes, so they're in and out of planes that are not pressurized. So they've had DVTs. So a guy has a DVT, that's a venous thromboembolism, right, which is a clot in the lower leg that called pulmonary embolism. It's not on the arterial side. That's a heart attack. It's complicated, but it's kind of hypercoagulable. It's kind of all the same thing. That's the aspirin and all this stuff. But if you have a genes for that, like factor V, von Linden, right, and then you're having DVT, you can't let that patient have a hemoglobin of anything much more than 17. See, I have different ranges, and I have to work with other. But when you send the patient to another doctor, they just say stop testosterone, and I say F you. We can't stop testosterone. We can't do that, doctor. So they just want to back away. So then you have to talk to the patient, lower the testosterone, microdosing. By the way, I think there's going to be some great data on that with enanthate and subcutaneous. This is just so new. And I think a lot of guys that are so sensitive to androgen, and I get them to lose weight, to sleep apnea, change the diet so they're more plant-based, even though I love meats. And I'm just taking every single piece of the erythrocytosis and the iron deposition. If their ferritins are high, you have to phlebotomize them. You have to. So don't just look at your hemoglobin hematocrit and let a doctor say don't phlebotomize or phlebotomize. You need to put that piece together. But this is arguably the most complex thing that I've developed over 20 years.
We've barely scratched the surface today. For more insight into hormonal health, why not explore our channel? We've got a wealth of content awaiting your attention, and you can also visit our website at balancemyhormones.co.uk. So, this is Mike from Balance My Hormones, your beacon in the fascinating world of hormonal health. And until next time, remember, knowledge is power, and your journey to wellness starts here with Balance My Hormones.